Hello and welcome to the EduTalk series hosted by Biotone, EduPartner School Program, and massage industry experts. With the growing interest and popularity of the EduTalk series, Biotone continues to support virtual learning and building massage community by connecting you with industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Today's expert is James Waslaski, an international lecturer, educator, and author of the Clinical Massage Therapy, a structural approach to pain management. He's an NCBTMB approved provider, a certified personal trainer with National Academy of Sports Medicine, plus teaches weekend seminars when he has time with the Center for Pain Management. With over 33 years of experience, James is a 2008 inductee into the Massage Therapy Hall of Fame and was recognized as Teacher of the Year in 2012 Canadian Massage Conference and the 2015 World Massage Festival. Let's listen and learn as James discusses quick manual therapy techniques to treat musculoskeletal pain for each area of the body in less than 5 minutes. He'll share highlights from 11 different classes and insights into his top 3 techniques to quickly address low back, cervical, shoulder, hip, and knee pain, including assessment and clinical reasoning to easily identify the precise manual therapy technique to eliminate joint and ligament pain, muscle imbalance pain, muscle tendon injuries, trapped nerves, and scar tissue pain throughout the body. And we have a lot to get to. Again, thank you for joining us tonight. Please feel free to chat questions during James' presentation, which he'll answer at the end. And again, please be sure you are muted and video is off. And with that, I'm turning it over to you, James. Welcome. Thank you so much. I know you have a lot to share. I'll exit and see you on the other side.
Thanks, Danelle. I appreciate it. And thanks to Biotone for this opportunity. Okay, let me click on this one. I'm going to share here. 1 second. Okay, I'm going to go with this PowerPoint and let's see if this meeting has been recorded. I'm just switching out here for a minute. So I'm going to go with the PowerPoints. We already went through my bio, so I'm going to go into some really important things with why this course evolved. So as Danelle said, I teach 45 weekends a year all over the world, and my audience is chiropractic, physical therapy, massage, athletic training, osteopath. And my wife said to me, if we could only do 3 or 4 things for each body part, what would we do? Meaning I could teach you 30 things for the back, I could teach you 30 things for the shoulder, but when my wife gets injured, we spend less than 5 minutes doing the top 3 or 4 things that everybody should be doing to, let's say, back pain, shoulder pain, neck pain, etc. So we're going to go ahead and go through this. Number 1, as you can see in the image, and I'm going to be demonstrating all this on mat. Number 1, I'm actually doing a technique that's assessing range of motion of the hip. And basically, we're going to be doing that and hydrating the capsule. So what I'm doing is I'm gently compressing the femur, checking the degree of internal and external rotation. And when I do that, then I'm actually trying to see what it feels like when the joint stops moving. And we'll learn that if it's a soft end feel, you need to rebalance the muscles. And if it's a hard end feel, you need to do something that brings in hyaluronic acid and synovial fluid to get the inner joint space moving. The next thing we're going to check is the ability of the iliums to rotate around the sacrum. Many people come in and they have an iliosacral torsion. One is anterior, one's posterior, and that's causing a lot of sacral dysfunction and SI joint pain. So if you look at the PowerPoint slides on the far left, my thumbs are at the ASIS, just to see if they're even. On the second slide, you're seeing my hands push the iliums apart. And what that does when you push the iliums apart in the front is it relaxes the ligaments in the back. When you relax the ligaments in the back, the muscles relax, and you can undo this SI joint problem in about 1 minute. And then you just take your hands and you make sure the ilium's rotating, because when someone's walking, the ilium should be rotating about 5 millimeters. And that's where the spine gets more functional and everything becomes better. So that'll be one of our top 3 techniques for low back and hip. And please keep in mind, I'm going to go through this quickly, but you will be getting a handout in the morning, which has the pictures of each of these steps. Your handout will be sent out by Danelle, and you will be getting that to show you how you can get to the table and just go step by step through this. So the third step we did after hydrating the capsule and getting interjoint hydration and getting the iliums to move around the sacrum is we stretch the hip flexors, things that are tight like psoas iliacus. Then we check for a weak gluteus maximus. Usually the glutes go weak because when you're sitting, like I'm sitting right now, and my brain's telling my glutes to neurologically inhibit. So when I go to stand up, instead of my glutes and hamstrings pushing me up, it would be my low back muscles. So we'll show you how to do that. And we'll go through the low back with those steps. So we'll hydrate the anterior capsule, we'll stretch the hip flexors, we'll check normal muscle firing patterns. And when someone raises their leg when they're prone, which is fire first is gluteus maximus, then the upper hamstrings should fire, then the opposite QL, same side QL. And then we'll just put the glutes on a stretch and stimulate them. I'll be using a myo buddy today to do the glute activation technique. We're also talking about a lumbar spine. If they have a normal lumbar spine curve, you leave it alone. If they have too much curve, you take the curve out. And if they have not enough curve, you do techniques that restores a normal lumbar curve in the low back. Now with the knee, I'm only going to probably do one thing because I did an experiment at the Florida Chiropractic Physician Conference. And when I did that, I worked on about 32 doctors. And all I did is 3 things at the hip, the ones I'm going to show tonight. I looked for tibial torsion. So I want to talk about tibial torsion. When you bend the knee, in the left image, you can see that the foot is laterally rotated. It's rotated away from the midline. So imagine when you drive your car, and your knee is bent and your foot has to rotate over to get to the gas pedal. So that laterally rotating foot rotates the bones above it, the tibia and the fibula. When those bones rotate, what happens is the knee gets twisted. And when there's a torsioned knee or a twisted knee, very common in the right knee, that causes about 90% of knee pain. So we'll show you how to assess for a tibial torsion, and basically we'll work one muscle, and that's the biceps femoris. And once we work and stretch the biceps femoris, the foot will straighten out, which means the femur will line up with the tibia, and all the things that were twisted, patella tracking, etc., will be more functional. So our goal in the knee is to check one most important thing is the femur lined up with the tibia, so everything in the knee is in a state of balance so that the movement doesn't cause more wear and tear, and the knee can heal itself from chronic pain. And then at the ankle, and Matt just let me be aware that his talus has got a little issue today, so it'll be good to see. What we're going to do is the bone that we're going to look at today is called the talus bone. The talus bone messes up all the other bones. So when you sprain your ankle, if the talus slides lateral, it can't allow dorsiflexion. If the talus slides medial, it can't allow dorsiflexion. And when the talus bone, which is here, doesn't allow the ankle to go up and down, then the metatarsals, the long bones, lock long. And then you have all kinds of ligamentous pain and nerve pain that your healthcare provider will call plantar fasciitis. But we'll show you tonight that the majority of foot pain on the plantar aspect of the foot is a dysfunctional talus, which allows the bones to go in extension, which locks the ligaments long. And the majority of foot pain is not soft tissue, it's ligament and nerve pain. And we'll explain that as I work on Matt tonight. And then we're going to look at the forward head with the technology of iPhones and people looking down all the time. The SCMs, which by the way, don't attach to the mastoid process. The sternocleidomastoid actually attaches mostly behind the mastoid process on the occiput. So as the SCMs get tight, it drives the head forward. If you look at the first image on the left, the far left image is a normal cervical curve, normal thoracic and lumbar curve. But if you move one slide to the right on image number 1, you'll see the head's doing this. It's starting to slide forward. And as the head slides forward from the SCMs, the suboccipitals also contract to level the eyes. So what happens in the head and neck is that the occiput goes into extension. C1, which is here, which is supposed to rotate over C2, is jammed. It jams the basilar artery. Then if you sleep wrong, C1 goes out and it jams the vertebral arteries. And these neurovascular migraine headaches are very common when you have a forward neck that the head has to sit on. So the primary muscles to treat that forward head and that extended occiput and those jammed and neurovascular bundles, if you look at image 2, there's nerves, arteries, and veins in there. And when they go out of alignment, if you have a cervical sprain or strain, you do not want a high velocity adjustment because a sprain means damaged ligaments and a strain means damaged muscles and tendons, and forced moving joint fixations like facet joints with high velocity is really considered a potential risk because it can actually stir up the previous ligamentous and muscle tendon injuries. So we'll be doing a check to see if you have vertebral artery insufficiency. Tonight, we'll be working your SCMs and your suboccipitals so that the head can turn 90 degrees. We'll be checking for neurovascular compression in the neck and trying to line up C1, C2 so that fluid can drain from the brain. Again, my wife is very prone to neck pain because back in the 70s, she did disco dancing and she did a lot of this stuff back in the disco area. And so jamming all those facet joints caused some arthritic changes in her neck. And they don't catch up to you till after you turn 50 or so. But then all of a sudden you feel this degenerative thing going on. So we'll show you my wife's top 3 favorite neck techniques. One is to release the facet joints. One is to stretch the lamina groove. One is to get upper cervical rotation. So there's 3 or 4 techniques for the neck that can make a huge difference in movement of the neck, pain within the neck, and chronic neck pain. So we'll be showing you, again, my top 3 or 4 techniques for neck tonight. And we're going to be doing real-time therapy tonight. But when the video comes out, you guys can slow it down, lay out your handouts tomorrow, and practice each step. But tonight, I'm going to just go through the real time that I would spend treating Matt's neck or shoulder or head or back. The other thing you'll be seeing is that you'll be seeing me warm up the fascia, stretch the SCMs, and then lifting the occiput off of C1, C2, which is what the SCMs are doing, is they're extending, they're pulling the occiput back. So we're going to lift it up so that the rotation in the upper cervical complex will come back. I'm going to try to make complicated pathology simple, because right now you're thinking, God, I don't know some of this anatomy. I don't know about joint function. I don't know about moving bones. But when we get on the table, I'm going to go super slow and just say, this is what technique 1 does. This is what technique 2 does. This is what technique 3 does, rather than just show you a bunch of random techniques. As you can see here, the suboccipitals on the left are basically locking the head into extension. So they pass across C1, C2. So if you look at the second image, here's the occiput, here's C1, here's C2. And when they get tight, they jam those 3 joints. And we'll show you how to correct that so that the basilar artery frees up. And we'll show you how to correct it so you can rotate your head all the way to the right and left. The other thing I'll do briefly, I have a whole class on trapped nerves. It's a whole weekend. And we look at bones on nerves, ligaments on nerves, and scars on nerves. We're going to look at the lamina grooves. We're going to look at cleaning up the lamina groove. That's image number 4, left to right. We're going to look at cleaning up those grooves. If you look at image number 2, left to right, we're going to look at opening those facet joints. Those are where all those nerves come out. We're going to look at soft tissue techniques that can encourage opening of stuck facet joints. And then we're going to look at restoring the normal lordotic curve in Matt's neck. And again, I'm just going to spend 3 or 4 minutes doing these 3 or 4 techniques on Matt. And that's really all the time you really need real-time therapy. And then I'm going to do a little release of the scalenes. We know the scalenes will cause neuropathy in the arm. They call it thoracic outlet, but the scalenes are really cervical muscles. And the scalenes attach to the first rib. So if we show you how to get under the clavicle and pull that first rib down, as you can see in image 3, my finger pads are on the first rib. When you take a deep breath, the rib's going to come up, so you'll let it. And when they exhale, you'll pull the rib down. And once you pull the rib down, then you can move the head away from that first rib, and then that stretches both upper and lower fibers. So if you look at image number 4, my hand is under Fran's neck. My right hand's on her first rib. And when she exhales, my right hand pulls the rib down towards the hip. And then my left hand moves her head away from the first rib to stretch the antermiddle scalenes. And if you look at the image 3, right above my fingers and right above my middle finger is the anterior scalene, and right above my middle finger is the middle scalene. And you can see how they wrap around those nerves that come off your neck. And so if you don't treat these, which is called thoracic inlet, you can't treat clavicular pec minor relationships for thoracic outlet. And so we'll show you these techniques tonight. I'm not going to go into detail about frozen shoulders, but you will be getting this, I believe, in your handouts. And I was flown to Kuwait to treat a really complicated shoulder that they said was frozen. But it wasn't frozen. It had scar tissue, which I treated with microcurrent. It had pain from inflammation and trapped nerves. And we have a whole technique, a whole 8-hour day, just on isolating all these injuries of the shoulder, look at clavicular rib space, looking at sternoclavicular scapular glide, and a really lot of good soft tissue care to make shoulders healthy. Bottom line is most people that are told they have a frozen shoulder, they don't. They have an injured shoulder, they have upregulated sympathetic stress, and they have pain, so they can't move their shoulder because it's hurting, and then the muscles tighten, and they do not want a therapist making it hurt more. They want someone that does positional release and strain counter strain. But the most important thing we'll look for in the shoulder is that a majority of the population have shoulder impingement. This supraspinatus is impinged. We're going to show you a technique that'll go over here, and it'll push that humeral head down, which will take stress off the long head of the bicipital tendon and the impinged supraspinatus tendon. That's something you see in probably the majority of the population, so we'll show that technique tonight. And then this is my top 3 shoulder techniques. The one on the left is stretching a tight pec minor. Pec minor usually locks the shoulders forward. So the one on the left is just lifting that pec minor back, and we'll show you that on mat. The second one on the left is actually doing a technique that relaxes the capsule, which is what holds the humeral head in place. Then is do a technique that stretches the capsule. And then the fourth image, you're finding the acromion and pushing straight down to drop the humeral head off the acromion, which increases subacromial space in there, and that gets rid of bicipital tendinosis, long head, that gets rid of supraspinatus tendon compression, and it gets rid of bursitis because the bursa sac sits in there. Just keep checking this 20, so we got 5 minutes. The last part of the shoulders, we'll just put the scapula. Scapulas are typically pulled forward and rotated up. So we'll pull the scapulas back and rotate them down so that we can relax the muscles in your back. The rhomboids in the back are usually stretched long because the shoulders and neck go forward. So the rhomboids get stretched long. So we'll put the scapulas back where they belong, and then we'll activate the rhomboids to wake up the nervous system. And we'll use the mild body of the spindle cell work to wake up Matt's rhomboids, because if we can put his shoulders back and drop his scapula down and increase subacromial space and then strengthen the muscles between the shoulders, we're going to explain to you that the worst stretch you can ever do is pulling your arm across your chest for many reasons. 1, the rhomboids are usually weak. 2, it decentralizes the humeral head under the acromion. And 4, it feeds the tight muscles in the front to trap the nerves. So we do not want to pull the shoulder forward. We want to roll the shoulder back and put the scapula back where it belongs. And that takes about 3 to 5 minutes to do what's the most important starting point for each part of the body. And then we'll look a little bit at elbow pain. Matt said he had tennis elbow. Believe it or not, that could be a nerve, that could be a ligament, that could be a muscle tendon strain, that could be a fixated ulna. In a longer course, we would sort up all the peripheral neuropathies coming into those little fingers, ring finger for a trapped ulnar nerve. We'll also look at the wrist. I can probably guarantee that 80% of the people have jammed carpal bones. So we'll be doing something that shortens all the ligaments in the wrist and checks the space of those carpal bones to balance out the wrist flexors and extensors in the wrist. And then we will look for a muscle strain if Matt has one in his elbow. And then we'll check deep core veins, tenosynovitis. When people do this test, when they put the thumb in and they basically wrap the fingers around and go this way, oftentimes these tendons hurt. So we'll release the opposite muscles and strengthen these, and that gets rid of deep core veins, tenosynovitis. We're going to go live here in a minute, but I do want you to have the barcode. We do a trip in Italy every single year, and it typically sells out. We do 2 trips a year to Italy, where we have breakfasts and lunches and dinners together. We go on excursions together. We spend the whole 7 days with the group. So Danelle will be sending you out something about that with the barcode for the Italy. And we have an Ireland trip every year too. So we'll talk about that and the information you get tomorrow. So with that being said, I'm going to go back to the larger screen. Let's see how I can click out of this one. Get out of the PowerPoint. That should go back full screen. And Danelle, can you give me the big screen on here? I'm still seeing myself on the smaller screen. I don't know if Danelle's listening in, but I see Danelle on the big screen on mine. So is there any way we can switch that, Danelle? Not sure.
You'll have to let me know, James, because on my screen, you're large.
Okay, well, I'll just watch my smaller screen then. So we're going to move this up, and Matt's going to get on the table, and I'll watch the smaller screen. There's going to be a little shift here, but let's come up with that table, Matt. And we're going to bring in the Cardone table. Can you just put your foot on the right side? We're going to come up with this table. I'm not sure why it. Let's look at view here. See if I can go big view here. Sorry about this little glitch.
James, someone suggested switching your view to speaker view.
Okay, just did.
And did that help?
I did it to speaker and it didn't change me from the small screen. I'll do speaker. All right. I think it has to be done on your end. So I'll just leave it the way it is.
I have it set at gallery.
Okay.
And
so basically I'm going to move Matt over and can you see his body on the table?
Yes.
Okay, great. So one of the things we're going to do with Matt is we're going to go to the low back and the hip first. In fact, let's start with the neck and work our way down. Usually I work from the core. So we're going to bring Matt in closer. And we're going to get a good view of this once we get a close shot of Matt. And I'm going to show you my top 5 things for neck release. So can you see Matt's head and neck and shoulders good on there? Yeah.
Yes.
There we go. So as you can see, in an 80% of the population, there'll be restricted right and left rotation. And what's interesting, when you have that, it's usually the occiput and C1, C2. So I'm going to get the little model of image of that real quick here. What did I get? C1, C2. So 80% of the population have an extended occiput. And underneath of it is C1 and C2. So here's the technique that you should start neck work with. You check flexion, you check rotation. It's a hard angle, so you shouldn't be stretching. But if I just grab Matt's SCM, which you want to take your shirt off for me, guys? Thank you. He's going to take his shirt off so we can get a better image of the soft tissue. If I just grab Matt's SCM, which is this muscle, and gently rotate it over, just gentle holding pressure. And the SCM does not attach to the mastoid process. It remotely does, but most of it attaches back here on the occiput. So if I start flexing the occiput and stretching the SCM, and then flexing the occiput, now watch Matt's rotation, we can actually stretch them all the way to 90. And if I do that on both sides, I'll just do this quickly on the left side since the camera is showing the right side. And then I come under the occiput and stretch all the suboccipitals. And then all I do after that for Matt is I'm going to just traction his neck and decompress the spine. So first technique was SCM with flexion of the occiput to unlock C1, C2. Second one was tractioning the spine. And then while I traction the spine, I'm gonna free up some of the nerve roots that are in that lamina. I'm gonna check the lamina groove and free up these nerve roots. So the third technique would be to glide up the lamina groove with some translation, keeping your thumbs nice and relaxed. And then traction the neck. And then the fourth one would be a little bit of side bending. And I'm just doing a little bit of overpressure with my thenar eminence. And this encourages opening and closing of stuck facet joints. So decompress the neck. And the most important thing is get under that occiput. Keep the head on the table. Now, Matt, tuck your chin and look down with your eyes. Stretch all those suboccipital muscles. Stretch all those suboccipital muscles in there. And I'll recheck my work now, Matt. You should have 90 degrees of right rotation. You should have 90 degrees of left rotation. You should have 45 of right and left lateral flexion. And then I'll just give them a bonus stretch and then look down with their eyes. So we keep that occiput, keep that occiput. Most important finishing touch is to keep that occiput up off of C1. Now, in a regular classroom, this would be a 6-hour practice time, just so you know, but I'm just showing when you get good at something, how you can do it in 3 to 5 minutes. Now with the shoulder mat, I'm going to do my most important thing. You're going to go face down. Well, mat is face down. I want you to know that the majority of shoulders have a tight pec minor and weak rhomboid. So if we could 3 things for every shoulder, I'm going to get this table so they can see Matt's shoulder better. If you could only do 3 things for every shoulder, and you're wondering probably why I've got Matt face down, but I want to work his pectoralis minor muscle. So underneath the scapula is the pec minor in the forward shoulder area. And if I put my finger pads under there, and I'll show you 2 views because I might be blocking the screen a little bit here. Stretch pec minor, which frees up the scapula. Relax the capsule and stretch the capsule and pull in synovial fluid. And then the most important one I want to show you on here before I do it on Matt. The most important one is you find the acromion and you find the capsule lateral to it and you drop the humeral head off the acromion, because what that does is unlocks the supraspinatus tendon. And that unlocks the long head of the bicipital tendon. And I did mention that this is real-time therapy. So your hand would be right there on the middle deltoid, and you would just decompress the humeral head. So I'm going to show it one time on this side. I'm stretching pec minor. You'll see the scapula lifting off the rib cage. Freeze it up. You're going to relax the capsule, stretch the capsule. Then your hand is going to drop the humeral head off the acromion. So basically, we're opening up that tight pec, and then I'm going to show you what to do with the scapula. The scapulas are typically upward rotated. So if this was standing up, they would be upward rotated. We need to downward rotate them. So my next technique for shoulder is to just take the scapula and pull it down towards his hip and in towards his spine. Take the scapula, pull it down towards the hip and in towards the spine. If you notice, I'm just putting things back where they belong, and I'm going to turn the table so you can see Matt's other shoulder when I do that. Basically, what you're going to do is put this here, grab the upper traps, drag the scapula, because that shortens all the rhomboids. And the reason the rhomboids hurt is that they're locked long. That shortens all the rhomboids. And then just decompress the humeral head. And I'll show that one where you're actually taking and finding that acromion. And you're going to push straight down, and that's going to create space in there. So you're just taking your head and pushing the humeral head down. Now, Matt, if you put your arms behind your head and neck for a second, please. And we're going to do a nice pec minor stretch. So with Matt's arms behind his head, bring your elbows up towards the ceiling. And this, I just lean back. So he brings his elbows up, and I just stretch pec minor. And what that does is that relaxes rhomboids. And then I do one more thing for shoulders. Matt, can you put your shoulder down towards the floor? So this, I put it on a stretch. And I've learned this, that if you do percussion and vibration, if you had percussion and vibration, and approximation, where you're just pulling the tissue back towards the spine. I use the Mile Buddy because it has percussion, vibration, and approximation in the and it shortens the muscles. So it stimulates what's called the muscle spindle cells. It takes the weak muscles, the infraspinatus, the teres minor, and the rhomboids. It approximates them back towards the spine while they're on a stretch. And this muscle approximation actually stimulates all those weak muscles. So you're just working from lateral to medial. You can push those erector spinae back into the spine. And that's kind of my shoulder routine. Now, Matt, we're going to bring the table down low, and as I go face down low, you're going to go face up as I do this now. So we're going to start going face up. And to do that, I've got the electric controls for the table. They'll drop the table down low. The Cardone table is a pretty awesome table. And again, you'll be getting a handout with each of these steps. And in the handout, you'll be doing 3 or 4 assessments for each body part. So I'm going to bring Matt here. And you can notice that I just want to make sure we got the best view. We put it on a small screen. Go ahead and I'm going to check rotation. Well, Matt doesn't have internal rotation. And it's a bone-on-bone like infill. So the first technique we do on all hips is we relax the capsule, so gentle positional release, gentle rocking to reduce unconscious guarding. And I lean back, which stretches the capsule, and this brings in hyaluronic acid and synovial fluid. And then I go to the next restriction and relax the capsule. And then I lean back, and that brings in hyaluronic acid and synovial fluid. And I go to the next restriction and just pump some fluid back into that inner joint space. And now Matt has good external and internal rotation. I hold the ilium, and Matt, can you feel your femur moving independent of your ilium? The reason I'm asking him is if he acknowledges with a thumbs up or a yes or a nod, it becomes brain therapy. You've got to connect what you're doing on the body to the brain for it to be functional. I'm just going to sneak by here, slide back over to the middle, and I'll check the other side. Again, internal rotation should be 45. Matt has 10. And lateral rotation, Matt has not been doing his homework since I saw him last. He is so busted. So
That's like my
so
cigarette.
relax the capsule. He's gonna blame the children. Yeah. Being daddy. But you gotta take care of yourself too. So we're stretching the capsule. And then I think my favorite technique of all times for low back. You have basically 2 iliums and 1 sacrum. And when you're walking, the iliums should be rotating about 5 millimeters around the sacrum. And when you're standing still, the sacral base should be level. Many people have an iliosacral torsion, which means a lot of long ligamentous SI joint pain. So here's a 1-minute treatment for SI joint pain. The first thing you're going to do is just hold that. I'm going to just show it, and then I'll do it on your hips. We're going to find the the ASIS. We're going to spread the iliums apart. And when I spread the iliums apart in the front, what it does, it relaxes the ligaments in the back. Then we're going to bring the iliums in, and Matt's going to use the muscles of his hip to simulate walking. When he walks, these 2 iliums have to rotate around each other. So now that you see, and then when Matt's walking, he could walk on his sits bones. He'd be shorter if he didn't have legs, but he could walk on his sits bones like that. And I'm doing that so he would smile and get a dopamine high. So again, slow it down now. Let's check the ASIS. He's low on the right, high on the left. So he has a right iliosacral torsion. I'll put my hands on his iliums, hooking on the inside. Matt takes a deep breath. On the exhale, I spread the iliums apart and oscillate the bones back and forth. Another deep breath. This time I'll pull the iliums in, and Matt, if you can make one leg go longer and one leg go shorter, and now you can see that the spinal engine is moving. And since Matt was low on the right, I'm going to bring him up on the right so his ASIS was even. Since that was quick, real time, Matt had this. We shortened the ligaments, we stretched the ligaments, we got the iliums moving, we leveled the sacral base so you can do cranial osteopathic or cranial sacral therapy better. And when Matt's walking, these bones are moving the way they're supposed to move, so there's no SI joint pain. Maybe we're going to go face down, Matt. Let's go face down on the spin and take a look at it. Okay. Now, that was two things I did for low back and hip. One, I got fluid in the joint. Two, I got the iliums moving around the sacrum. The third one I do on everybody as a part of a checklist is I hydrate the capsule by pushing in synovial fluid and hyaluronic acid. Matt, gently push your knee into the table to fatigue your psoas. 5, 4, 3, 2, 1. Matt then lifts the leg up. I counterforce the SI, so I'm not jamming out 5S1. And of course, I'm going to do it cross body. I wouldn't do that, but I'll do it for the sake of the camera. Gently push into the table and relax and lift the leg up. And this one I can't because it's more encapsulated. So I do have to do the first piece. So with Matt, we can't stretch the left iliopsoas because there's not enough synovial fluid. And this is the assessment part that adds a new technique. And then back to basically, now Matt push into the table and lift up. And notice I'm not letting his ilium and sacrum moving. And nice stretch. Good job, Matt. And then we'll put his glutes on a stretch. 90% of the population have weak gluteus maximus. As you'll see with Matt, if I touch his gluteus maximus hamstrings, opposite QL, same side QL, raise this leg up, Matt, and that's very delayed. Matt has what I call gluteal amnesia. He forgot to do his exercises. So when he does that again, what's working is his hamstrings and QL. So if we don't activate that, we can't treat his low back. So if I check this side, a little bit more active on the right, very, very, very inactive on the left because you have a left iliosacral torsion at this point. So what we do with glutes is we take the foot and put it off the table. In fact, let's show it on this other side. Just let the knee drop off the table. I'll break them out of body. Matt is one of my TAs. There aren't very many clients that know how to move in the position of my treatment. So Matt is one of my awesome teaching assistants. I'm going to come up with this table a little. Let me move in here to pull the table up. I'm going to come up with the table so we can see Matt's leg dangling off the table. Nice electric cardan table. You can see gluteus maximus is on a stretch, and then I just get in and I do fast-paced spindle cell work. If you've studied with my good friend and colleague Eric Dalton, I did learn this from him. And what Eric does is fast-paced spindle cell work using his fists, and then he usually plays Cotton Eye Joe during that and does he moves better than I do when he does this, but I like using the mild body. It's the same effect. Approximate, stimulate the muscle fibers. You can get into TFL, get into glute max if you want to have percussion, vibration, and in a minute you'll see active glutes and less active low back. So we'll split over the middle of the table, buddy. With the spindle cell work, you're going to see this pop up before these contract. So I'll bring you a little bit closer to the camera. Go ahead and raise this leg up, and you can see real active glutes here. When you think of the Olympics that just went on, those winners of those 100 meters and those marathons, they had movable iliums. They had glutes that could push them forward, not low back muscles. And their stride length was drastically increased because the psoas could lengthen. So this is critical too for performance enhancement in addition to pain relief. And the last thing we're going to do is twofold. We're going to check tibial torsion. So I'm going to bring the table this way again. And I'm going to bring this up so you can see Matt's foot when I bend it. When I bend Matt's right knee, the foot is rotated out. Here's where it should be. It's rotated way out away from me. What that means clinically, and the reason this is my most important checklist for knee pain, what that means clinically is that Matt's tibia, here's the femur and the quads, here's the tibia, here's the patella. So Matt's femur is rotated out about 30 degrees. So the patella is tracking, the ligaments are twisted, and the meniscus is twisted. So he's going to start to damage the inner cartilaginous space and trap nerves of the knee. So what you do is you basically bend the knee to 90 degrees. If it's turned out, you stretch this lateral hamstring, the one on the outside. So I'm going to turn so we can see this stretch. So this hamstring is called the biceps femoris. You can get some muscle in there, some blood flow in there. The biceps femoris attaches to the proximal fibular head, so it causes these two bones to turn out towards me. So to stretch this, Matt, I'm going to have you turn your foot out towards me. 5, 4, 3, 2, 1, and then I'm going to give him a little bit of joint space, a little traction, and then I'm going to turn his foot back in. Turn your foot out gently right now. 5, 4, 3, 2, 1, and correct the tibial torsion. Now we can see the foot is straight forward. That will be better quadricep function because the femur is now lined up with the tibia. 90% of the time, if you just do the 3 things I did on the hip, or 4 things, you get the torsion out of the knee and do what I'm going to do next. 90% of knee pain goes away with just those 5 techniques, which is why you can do a lot in 5 minutes. Let's go supine, Matt. We're going to check out your talus bones. Now, for Matt, I saved the best to last because he warned me about his talus bone before he got on the table today. So I'm going to show you his foot and ankle. The thing about ankles is you can't treat foot pain if you don't have a functional ankle. You can't treat foot pain if you don't have a functional ankle. The talus bone sits in this space between the calcaneus and the tibia. If you sprain your ankle, it slides anterior and lateral, and it blocks the joint from moving. That's if you supinate. If you pronate, it slides valgus or medial. And when the talus isn't centralized between these bones, the foot can't go up and down. So when the foot can't go up and down, what happens is the metatarsals go up. It long locks the ligaments, and then 90% of plantar fascial pain is ligaments and trapped nerves that anchor themselves on these bones. So the most important thing to check is the talus. And the thing about that is 80% of the people have had an ankle sprain and have an abnormally positioned talus. So 80% of the time, you can't stretch their calf muscles. So the checklist is you try to dorsiflex the foot. I'm going to show this foot, and Matt has no dorsiflexion. Now, if you were in a stretching class, you would not be able to stretch gastrocs and psoas. It's clinically impossible until you get the talus out of the way. Now, because I'm really good massage therapist and not a chiropractor, I can't do a high velocity thrust for that. But what I can, as a good massage therapist, I can put his foot on my tummy. I can pull the bones together to shorten all the ligaments. When you take our longer class on foot and ankle, it talks about positional release of articular ligaments. It means you're shortening ligaments that cause the muscles to calm down, and also causes the pain in the ligaments to go away, which allows me then to go under Matt's calcaneus, wrap gently around his talus, which is below the malleolus bones, then decompress the ankles. So I'm going to just brace this table so it doesn't slide since I got the wheels on there. Decompress the ankle with some traction, and then I'm just going to slip his talus back in. So now, Matt, bring your toes to your knees because you can, and for $50 tip to me, I'll do this one. Just kidding. Matt's like, oh, I don't think so. So shorten the ligaments, web around the talus, traction the calcaneus, and it slips back in. Now, so we checked ankles, knees, hips, shoulders, neck, back, elbow. I am going to say one thing on elbow, then I'm going to do a Q&A because I think we're running out of time here. Yeah, we got 5 minutes. Which elbow bothers you, buddy? Okay, good. That's closer to the screen anyway. So with elbow pain, is it medial or lateral? Let's get the screen on this a little bit better.
Medial.
So your doctor would call this medial epicondylitis or medial epicondylosis or golfer's elbow or tendonitis or tendinosis, but that doesn't tell us anything. I want to know with Matt, is it a tendon strain? Is it a ligament sprain? Is it a fixated ulna? Because the ulna bone's right in that space right there. Is it a fixated ulna? Is it an articular ligament sprain? Is it a joint fixation? Or is it a muscle strain? And if it's a muscle strain, which muscle? Because I'm going to narrow it down to the 1 or 2 things that Matt actually needs. And keep in mind, do all your relaxation stuff too, massaging all these muscles on top of doing this work feels awesome. So I love when I do clinical, when I get my treatment, I book 2 hours. The first hour is a clinical checklist like this. The second hour is totally relaxation. So I'm concerned about people that put down relaxing massage because it reduces stress and it calms down the sympathetic nervous system. So here we go, Matt. We're going to check joint function. First of all, is there any referral into your little fingers when I do that?
I have a little bit.
So Matt has a trapped ulnar nerve. I want to show you how to treat that. You basically supinate, and you'll find this. Matt has 60 degrees of restricted, his 60 degrees or 30 degrees short of normal supination. So with a trapped nerve, you've jammed your elbow. So what you do is you shorten the ligaments, you do a little distraction, and then you stretch the ligaments, and that unlocks extension, that unlocks pronation, and now all your range of motion is back. Now, if it was a trapped nerve, it might not be a muscle strain. The muscles that attach in this area are the flexors, especially flexor carpi ulnaris, the bicipital aponeurosis, and the pronator teres. So I'm gonna do 3 muscle tests. When you flex, any pain in the elbow? Anything? So it's not a flexor strain. We'll leave that alone and just stretch those. We'll check your pronator teres. When you pronate, does that increase pain in your elbow? Okay, so the culprit is this pronator teres, which is kind of a good way to end my presentation. Because the median nerve runs through the pronator teres, and it sometimes causes numbness in the index finger, thumb, middle finger, ring finger. So if this muscle is tight, it can cause elbow pain if it gets a strain, and it can trap the median nerve. So the way I treat it, Matt, you're just going to slowly pronate and supinate. I'm going to bring this to the camera a little bit more. So the pronator teres is right here. When you pronate, I'm going to hold, and when you supinate, I'm going to give it a stretch, bring up the median nerve, and then hold and stretch. And now we're going to isolate this muscle strain. When you pronate, tell me when I'm on it. Okay, so I'm going to do some multi-directional frictioning. As you take my longer trainings, we do one technique at a time, and we spend 5 minutes per technique. So after we show you 40 techniques, we choose the top 5 based on assessment. Frictioning does not realign scar tissue. Frictioning lays down fibroblasts. If you don't follow frictioning with eccentric loading, you don't realign scar tissue. So Matt, you're going to shorten that muscle. I'm going to pin it. I'm going to put a little eccentric load on that tissue. Shorten that muscle, pin it, and eccentrically load that tissue. And now the nerve is free. The flexor carpi ulnaris is free. Now pronate and see if you still have anything. So Matt's tendinosis and his trapped ulnar nerve has been treated. And then I'm going to go back to, I'll go back to the small, so just a review. You can go to the big screen if you want. I'm going to do a recap and say I covered a lot in 30 minutes. But typically in the real world, my wife wanted this to be a course where you'll spend 2 days learning the upper body and then 2 days the lower body portion. So you can pick and choose which technique you actually need based on assessing for every technique. So I want to thank the audience. I want to know that Danelle's going to send you a handout tomorrow with all of my DVDs, and my digital online are going to be discounted. We have exactly 5 DVDs, which is all my updated information, all my assessments, treatments, and exercises. And that is the non-caffeinated version in those DVDs of what you experienced when I do real-time therapy. I do work a little bit slower, but in real time, you can do a lot in 3 to 5 minutes. So I'll go back to Q&A, and I'll go back to letting Danelle, and thank you, Biotone, for this incredible opportunity to introduce you to integrated manual therapy and orthopedic massage training. So I'll have Danelle come back on.
Okay, thank you. Thank you, James. Oops. Everyone, we have time for questions and comments. What I would like to mention, since there are a lot of new names attending tonight's EduTalk, is that the day after the talk, you will receive an email follow-up, which will include the recording of James's talk. It will include his contact information. It will include his offer for the 30% discount on DVDs and streaming videos, and a code to use for that. And I don't know why I go blank. And it will have the QR code for Italy. And if James supplies me with the one for Ireland, I'll include that as well. So again, watch your inbox, please, for the follow-up email. Also, If you don't see it in your inbox, please check spam or your junk folder. Now, James, one question that came in earlier was, what is the exact name of the massager tool that you were using?
It's called the MyoBuddy, MYOBUDDY. And since I work with the owner, I sell it for about $150 less than Amazon. So it's MyoBuddy, and it's got 60 hertz of compression and vibration to stimulate weak muscle activity.
Okay, I will include that information in the follow-up as well. Let's see. Irina is saying, now I can help my people without killing my hands. And silly question, do I use any oil or butter or go dry while using these techniques?
And I use Cryoderm. I've been instrumental with them in their product development. And my wife and I have helped develop an ointment that hooks the fascia in a cream. So I do use a light few drops of cream and lotion. But I do think there's so many products, including your sponsors' products out there, that are amazing to create the perfect viscosity. And I think especially if you have dry skin, I recommend you using a lotion or a cream in supplement for this care. Ida did not use lubricants, but I like the relaxation stuff too. So please add all that into and use a good product.
Thank you. Let's see, we have some volunteers to replace Matt. So, so if you need future volunteers, also a great tutorial, a lot of thank yous for this. Are your clients always clothed during massage? Wondering how to incorporate techniques into a spa setting.
So I teach at a lot of the major spas throughout the world. And so I do both. I do where you're draping, but personally, I have people wear a pair of shorts and a sports top. I thoroughly clean the table between clients, but they wear a pair of shorts and a sports top. And I work more like a physical therapist because I can access everything that way, including palpating all the muscles. So a pair of shorts and sports top. So I haven't had to wash sheets for about 25 years, which is kind of a nice little perk.
And James, someone is asking, where are you located? And that would be the Center of Pain Management as well.
I, believe it or not, just got licensed in Texas. I took the NCBTMB in February, 33 years into my practice. I'm 20 minutes from my mentor, Benny Vaughn. And I will be doing some clients starting probably around November, but I do travel 45 weekends all over the world to 15 countries in almost every state. If you go, you'll see my schedule on my website. So I'm really never home. As you know, Danelle, I've been on the road in a classroom or a plane for 32 days now. So because this is my passion, it's not my job anymore.
Well, I know you are probably the hardest working guy out there in the massage industry. And, I personally thank you for all you do. Let's see. When will you be in Los Angeles, California?
We are not in California this year, but I'll be looking at doing something. If they keep in touch with our website, www.orthomassage.net, www.orthomassage.net. Right now, I'm booked into March of next year. There's nothing currently in California, but I will be booking something there in the summer or fall of 25.
James, will you be at AMTA National in Tampa?
I have gone to AMTA National every year since I was a student in 1990. So my beautiful wife, friend, and I will both be there with our smiley faces, greeting and having fun and reconnecting with everybody.
Okay, and are you teaching there?
Teaching this year at the AMTA National, but I go every year, whether I'm a vendor, whether I'm just showing up to visit friends. We always go to AMTA National, so friend and I will both be there, yes.
Okay, great. Would love to come to your class in Montana, Kalispell preferably. Do you do classes up in Montana?
I'm doing 2 years ago and 3 years ago, we did the AMTA Montana conference 2 years in a row. And by the way, with that being said, if your AMTA state chapter wants me to come and do a conference, we're scheduling everything right now into 225. If they just call Allison and they let us know, we'll send you out a media kit, we'll send you out a DVD sample, we'll send you out all my course information. I've done every AMTA state, but I want to come back to every state again. So let your AMTA know that if you, all they gotta do is call our number and we'll book a seminar in your state.
And again, in the follow-up email, James's contact information, website, Phone number, email will be in there so you can follow up with him directly. And I'm not seeing you. We had one person see you, Italia Bella. So I think that's it. I think that's all the chats I see coming in. A lot of thank yous, a lot of great information. One comment, it was mind-blowing.
And I'd like
So
to give Matt just 1 minute just to give his name and his website, because he's one of my top teaching assistants and has an incredible business. Just maybe 30 seconds, just your name. Website.
Yeah, so I'm Matthew Molds. I'm the inventor of the Scar Pro, and it's thescarpro.com. It helps to break down restrictive and painful scar tissue.
So look him up, and he's also been in my TA for many, many, many years, and I'm grateful. I called him 3 hours ago to come, and he showed up.
Anytime, yeah, you can call me 30 minutes and I'll be here.
Matt, how do you spell your last name?
Moulds.
BS. Oh, okay. All right. Well, I'll include that in the follow-up as well. Many thank yous. And I would like to also say, mark your calendar for upcoming EduTalks. If you're not familiar, EduTalks Diabetes Series was launched last May 2023. And I think you'd find it very interesting as massage therapist. Many of the EduTalk presenters for diabetes are from the massage industry. On August 13th, we have Dale Alexander, who is a past EduTalk presenter, presenting an evolutionary perspective on diabetes, how bodywork may assist. And again, that's Tuesday, August 13th. On August 20th, we have Tanya Rodriguez, implicit bias training, working with diverse populations. And that will be a good one for your practices. Thank you so much, everyone. Thank you, James. Thank you, Matt. Thank you, everyone, for all the work you do as massage professionals. Please join us in the future. And again, if you don't find the follow-up in your inbox, please check spam. All right, I think we covered it.
Thanks, Janelle, and thanks to Biotone. I appreciate this opportunity. Thank you.
Okay, and thank you, everyone. Keep doing what you're doing and be safe. Take care. Bye.